السيشن دي ويبينار والجيست سبيكر عندنا is an old friend Professor Paul Willthon. هل ممكن نبطل كلام يا جماعة؟ رجاء الالتزام بالسايلنس. بول ويلتون ده نعرفه من سنين طويلة واشترك معانا في الناشونال هايبرتنشن سيرفي، وهيتكلم على الرول اوف كارديوفاسكولار ريسك كالكوليشنز ان مانجمنت اوف هايبرتنشن. المحاضرة بتاعته مسجلة، هو مش معانا على الانترنت، انما بعد ما نخلصها ممكن احنا نوجه له اسئلة ويجاوب عليها. فنبتدي.
It's a great pleasure to be with you today for your annual scientific meeting, and always a pleasure to be with my many very good friends and colleagues in Egypt. I'm going to talk about the role of cardiovascular disease, risk calculation in the management of high blood pressure. I have no conflicts of interest, but I do bring greetings from all of my colleagues in the World Hypertension League. I'm going to discuss three things. First, the impact of cardiovascular risk and blood pressure treatment decisions. Secondly, it's a great pleasure to be with you today for your annual scientific meeting, and always a pleasure to be with my many very good friends and colleagues in Egypt. I'm going to talk about the role of cardiovascular disease, risk calculation in the management of high blood pressure. I have no conflicts of interest, but I do bring greetings from all of my colleagues in the World Hypertension League. I'm going to discuss three things. First, the impact of cardiovascular risk and blood pressure treatment decisions. Secondly, the use of cardiovascular risk for treatment decisions or antihypertensive treatment decisions, the advantages and the challenges, and what do the guidelines recommend, and then what are the methods that are being used to assess cardiovascular disease risk and the guidelines. So let's start with blood pressure and risk of cardiovascular disease. And we've known for years in individual studies, particularly in cohort studies and in pooling of cohorts, that there's a striking relationship from the lowest pressures in these cohorts up to the highest, from about 110 systolic up to about 180 systolic. It's steeper at younger age where you have elevations of blood pressure that are isolated, and it's very impressive, but a little less steep at older age, which we have many risk factors, but the absolute level of risk, of course, is much higher at older age. It's there for systolic, it's there for diastolic, it's there for all the major outcomes, stroke, ischemic heart disease, heart failure, kidney disease, you name it, it's there. And of course, in these cohorts, blood pressure was measured fairly carefully. In contrast, in clinical practice, we know blood pressure is not measured very well, but even there, it's such a robust predictor of risk that even in studies like this one here, this is a large electronic health record linkage study of about 1.25 million people. You see the same pattern. We're showing it in the opposite direction here, but it's there for systolic, diastolic, and every outcome. And that was extended recently in a very nice study by my son, nothing to do with it, Seamus, who many of you know. He looked at participants in the multi-ethnic study of atherosclerosis, and he selected out individuals who were at very low cardiovascular risk and had a systolic between 90 and 129 millimeters of mercury. So a category of pressure lower than has traditionally been looked at in the cohorts, in the meta-analysis of cohorts. And what he showed is there was a striking relationship between blood pressure at this level prospectively with the development of other risk factors, with coronary artery calcium, which is the area he's most interested in, both single vessel disease and complex disease, and very importantly with atherosclerotic events. And very, very important observation, suggesting that pressures that are much lower than we normally characterize as quote unquote normal, or what are optimal for things like the avoidance of the early stages of plaque development and atherosclerosis. So we know there's a striking relationship between blood pressure and cardiovascular risk, even if you measure blood pressure badly. We also know is that at any given level of blood pressure, there's tremendous variability in that risk. And I just show here for systolic of 130, and you can see there are going to be some people here who are very low risk. So over the next 10 years, there's very little likelihood that they would have an actual event. And on the other hand, there are people up here who have a very high likelihood of having an event over the next 10 years. So blood pressure is important, but on its own, it's not enough. And characterizing it by underlying level of risk, in other words, how many other risk factors are present, really helps to determine whether somebody is likely to have an event. And if your treatment is based on probability of having an event, well, if you're trying to avoid an event, there's no point in treating down here because they weren't going to get an event anyway. And on the other hand, very likely, high likelihood of events here, so treatment would make great sense. When we look at the clinical trials and we look at a reduction in relative risk, in other words, risk ratio, it is fairly constant over baseline underlying cardiovascular risk from lowest to highest. Now, bear in mind that in these trials, everyone is at high risk because you don't recruit people into the event trials unless they have a high likelihood of an event occurring over the period of the trial. So it's lowest to highest, but it's really high to very high. In contrast, if you look at what's really important to the patient, and that is absolute risk, there's a very striking relationship. So there's a nice reduction here, but an even more striking reduction when you get to those who are at highest risk for cardiovascular disease. So that tells us that looking at cardiovascular risk really has a big impact on our treatment decisions. And that has led some people to really say that is the only approach we should use. So there are a number of very fine colleagues who have concluded that measuring blood pressure is very difficult. We don't do it well. We misrepresent who has and who doesn't have high blood pressure. It's just too difficult, and we don't do it right. So they're saying basing antihypertensive treatment on underlying cardiovascular disease avoids those challenges and the consequences of inaccurate blood pressure estimation. And when they look at meta-analysis of treatment trials, particularly in the blood pressure lowering treatment trialist collaboration, of which I was a founding member, they've said, well, look at baseline level of blood pressure. And if we stratify by baseline level of blood pressure, we see the benefit of antihypertensive treatment at any starting level of blood pressure. So they're saying even if you have a low starting level of blood pressure, as long as your underlying cardiovascular risk is high, which it is in these trials, there's benefit to treatment. So that's their take on it. There's also some observation analysis. I wouldn't put too much weight in them. I think there are a lot of flaws. I won't go through them today, but I've discussed them in the literature in some detail. I think, one would have to be very cautious about them. The other point that those who favor the use of risk predicting for any hypertensive treatment decisions make is that risk factors cluster. Many adults who are at high cardiovascular risk have high blood pressure. It's a strategy that is very popular in some journals. The Lancet in particular advances this strategy quite a bit, and they've written or had people write a number of editorials. Many of them not, I don't think, completely fair and reasonable. Nonetheless, it's a journal that advances this approach. And it is the national strategy in New Zealand. Roy Jackson, the leader in this particular area, and he's a strong advocate for using cardiovascular risk rather than risk factor identification and treatment. So those are the pluses. Now the limitations, I think, are very substantial. So the claims of superiority are really based on post hoc studies and clinical trial databases and non-concurrent observational studies. There are no randomized trials that document this approach. In contrast, when we look at managing risk factors, for instance, high blood pressure, we have abundant, high-quality randomized controlled clinical trials, which really are the gold standard for treatment recommendations. I think the other big problem is very limited availability of validated instruments for measuring risk. If somebody hasn't had an event, it makes it easy to determine they're at high risk. Then you're stuck with trying to use some instrument, and there are very few countries that have valid instruments. The US, Europe, New Zealand. After that, you're running thin. All of these instruments require lab values, and in some countries, this is very difficult, if not impossible. Requiring risk estimation has the downside that it might delay or at least or completely avert treatment. That would be a big problem. And we know that even in the countries like the US and New Zealand, where there's a great enthusiasm for the use of risk prediction, only a minority of clinicians actually follow it. Even when you ask cardiologists, and 100% of their guidelines are based on risk estimation, 30% of them will tell you they're using it. Now that's probably optimistic because people like to say they're using things when they're not. So we know that even though you make apps available and so on and so forth, it's hard to get people to change their pattern of care. And until this is in the electronic health record, it's difficult to get it to be used. And of course, even if you had a valid instrument, it's imperfect because you're taking a group estimate and you're trying to apply that to an individual. And the last challenge is once you get to the lower age ranges, we don't have instruments that are particularly helpful. We have lifetime estimation, but the traditional risk calculators don't apply, usually under the age of about 40 or 45. So given all of those challenges, most clinical practice guidelines that deal with blood pressure tend to use a combination of blood pressure level and cardiovascular risk for their treatment decision recommendations. And I think certainly in the US guideline, we put even stronger emphasis on risk estimation as you get to less dramatic forms of high blood pressure. So this was our take on it. I haven't thought about it quite a bit. So we said, if you're down here at low levels of blood pressure, of course, lifestyle improvement is always important, and it becomes even more important as you get up here to elevated. And we said up here at stage 2 hypertension, of course, you have high pressures, you're very likely to be at high risk. It's always a good idea to combine lifestyle and drugs. And when you're in this range here of the 130, 139, 80, 89, that's where it really becomes critical to understand whether somebody is at high underlying cardiovascular risk. Have they had an event? Of course, they're high if they have. Or if not, have they got at least a 10% likelihood of having a risk over the next 10 years? And we said if that was the case, then you should probably combine any hypertensive drugs with non-pharm. If it wasn't, you really ought to try very hard to use non-pharm. And in the US, this here was about 30% of adults. This was about 70%. We put out a scientific statement later on saying if you've really done a good job in trying to apply non-pharm and the pressures are still high, especially in certain subgroups, and the lifetime risk is high, it's not unreasonable to introduce monotherapy as well. So that was our take on trying to interpret the data. We looked at cardiovascular and we said, obviously, if you've had an event, you're at high risk, and if there was no event, we used the cool cohort equations. That just takes the major cohort studies in the US and pools to get better estimation than we used to get from using framing them on its own or any single cohort. And that approach has been validated well in the US for whites and blacks. It's imperfect, but pretty well validated between the ages of 40 and 79 years. We know that this approach doesn't work very well in other countries. For instance, it's been tested in New Zealand. It doesn't work well, particularly in the Aboriginals in New Zealand, the Maoris. So these are pretty specific to the populations in which they've been validated. We recognized that many people weren't going to actually do a calculation, and we said it was reasonable to assume high risk in adults who had stage 2 hypertension or stage 1 hypertension if they were of older age, the diabetes or the chronic kidney disease. And we did that based on data. It wasn't just an abstract idea on our part. We looked at the data, and I'll show you that in a moment. And we said for adults less than 40 years, considered the use of lifetime estimation of cardiovascular risk, and we made that available on all of our apps. So here's what we saw in Haynes when we looked at overall risk of cardiovascular disease and then the risk in those subgroups, the phenotypes that were older age, had diabetes, or had chronic kidney disease. And you can see straight away that these are pretty decent phenotypes for identifying people at high cardiovascular risk. And I won't go down into the details here, but it holds up pretty well. The other thing that we noted was if you had a combination of diabetes, diabetes mellitus in particular, chronic kidney disease to a lesser extent, you are likely to manifest that high risk at a much younger age. The difference between those with no diabetes or CKD and those with diabetes is about 12 years when, on average, people manifested with high risk. So pretty useful phenotypes for clinical practice. In the World Health Organization guidelines, which we published in 2021, we of course were looking at middle and low income countries, in many instances countries where it is much more difficult to find laboratories and really to find even physicians in many instances. So we made recommendations for initiation of antihypertensive drug therapy that were very similar, in fact, just about identical to what's in the ACC/AHA guidelines. So we said, a confirmed accurate diagnosis of hypertension, that's when you should introduce drugs in addition to lifestyle. And if somebody had existing cardiovascular disease or if they were at high risk cardiovascular disease. And we made strong recommendations here. The level of the evidence varied. The European guidelines has a somewhat similar approach. So they would say down here, high normal lifestyle, consider drugs when there's very high risk, and then grade 1 hypertension, immediate drug treatment, and so on and so forth. So not identical, but same general pattern. And they, of course, use a different approach to estimating risk. They use SCORE, which has been validated in Europe. There's been a more recent update on SCORE. It's a little more complicated. We try to keep ours simple. Basically, 2 levels of blood pressure. You have high blood pressure or you don't. And you have high risk or you don't. It's a little simplistic, but it's much easier to implement. Here you have many different categories of blood pressure and many different categories of risk, so it's a little more complicated. Truer to biology, but more complicated to implement. The Canadian guidelines are the ones that really emphasize the use of cardiovascular risk for antihypertensive drug decisions. So they would say, if you're down here and you have high risk, and you're older than 130, if you have microvascular disease or other cardiovascular risk factors, then you want to introduce drug therapy 140, 160, or diastolic less than 90. And I say if you're really at low risk, if you don't have microvascular disease or any other risk factors, they would let pressures go as high as 160 over 100 before introducing drugs. So we all vary a little bit on our view of the data. But I think the one thing when we step back and say, okay, we can talk about the nuances, but the big picture is appalling. And we all agree to that. But if we look, even at 140 over 90, the number of people who are aware worldwide, and especially the number of people who are being controlled, and worse than that, the number of people in low and middle income countries like Egypt, the group we were most concerned about in the WHO guidelines, it's appallingly low, less than 8% the last time we looked. And that's sad because we know what to do. What works well in the US, what works well with Kaiser Permanente, with the Veteran Administration, with many other systems there in the US, is what works well in other countries. We just had a powerful report from China with the barefoot doctors and village doctors. Very simple algorithmic approach, affordable meds, 14.5 millimeters difference in systolic blood pressure. So we know what works. What works is really a scheme where there's institutional or country commitment to achieving the goals, and more or less what we have in the WHO Hearts program, health promotion, simple evidence-based protocols, not complicated, both for lifestyle and for drug therapy. Reliable access to affordable medication. This is absolutely essential to be successful. And I think that's probably what was most important in China. Community-based, patient-centered care, preferably team-based care. We know team-based care works way better than individual physician care. And tracking systems to make sure that we're on track. We're identifying people who need the care they're getting. We're identifying that they're getting their meds, filling them, they're taking them, et cetera, et cetera. This approach works really well. We know that. And so there's no rocket science to this. So cardiovascular risk studies is important for antihypertensive drug treatment decisions, especially in those with less severe hypertension. A minority of guidelines recommend basing antihypertensive drug therapy decisions entirely on level of cardiovascular risk, but most contemporary blood pressure guidelines recommend using a combination of blood pressure level and cardiovascular risk with varying emphasis on the latter, all the way from just up to what's in the Canadian, huge emphasis on it. There are many challenges associated with cardiovascular risk estimating tools and their use in clinical practice. So that's my summary of the situation. And it's a great pleasure again to be with you, and thank you for having me. Bye, everyone.
In summary, الكلام اللي قاله بول ويلتون للأسف إن ما فيش مجال للمناقشة، إنما المسج is clear إن الهايبرتنشن بيكتسب خطورته وأهميته من حاجتين: من الليفل اوف بلاد بريشر، من الاسوشيتد cardiovascular risk factors. فبالتالي الريسك فاكتورز لها دور مهم. فممكن two patients with the same level of blood pressure ان واحد منهم مجرد فولو اب ولايف ستايل والتاني هبتدي له علاج على طول، وبناء عليه لابد in the evaluation will follow up of hypertensive patients we have to look for risk factors في الage والgender والfamily history, cigarette smoking, dyslipidemia, diabetes, coronary kidney disease. وبناء عليه احنا we make our decisions. ممكن two patients with the same level of blood pressure. واحد هعالجه، واحد will be follow up. واحد will be at risk ان يجيله stroke او coronary events او heart failure او renal failure، التاني مش هيجيله حاجه. فبالتالي مهم when you see a hypertensive patient you have to look for the presence of other risk factors، لان دي هتخليك تاخد القرار بتاع بدايه العلاج، تدي ادويه ولا لا. وده تقريبا ملخص الكلام بتاع بول ويلثون. هل في
انا بس هسال الاستاذ الدكتور محسن بيه، اولا في ماني اسسمنت اوف كارفاسكولار ريسك كموداليتيز، من بدايه فرمنجهام لكيو ريسك لاريك اسسمنت، ويمكن في ابديتنج لكل الميثود دي. يعني في حديثا اضافوا السينستي للريسك، واضافوا الانتي هايبرتنسيف، واضافوا السوشيو ايكونوميك ستيتس في الريسك اسسمنت. انا في نقطه برضو يمكن الحاجات دي محتاجه ان هو تبقى ابديتنج دايما. يعني هل انا لما بحط الانتي هايبرتنسيف تريتمنت تبقى مطلقه ابسوليوتلي، ولا ممكن الانتي هايبرتنسيف في حد ذاتها الكلاسيفيكيشن لها دخل برضو في المانجمنت بعد كده؟ يعني انا لما احط الريسك ده اسسمنت واكتب ان مثلا ده بياخد انتي هايبرتنسيف ميديكيشن ولا لا، هل افضل انا اشوف هو بياخد كلاس ايه؟ يعني بياخد كالسيوم شانل بلوكر، بياخد اس انهبيتورز، بياخد بيتا بلوكرز ولا لا؟ النقطه الثانيه برضو في الاسسمنت، هل الفاميلي هيستوري مهمه جدا طبعا في الاسسمنت، بس هل الفاميلي هيستوري اوف هايبرتنشن بيرسي، ولا الفاميلي هيستوري اوف هايبرتنشن انديوز كومبليكيشنز؟ يعني بمعنى ان انا في فاميلي هيستوري بهايبرتنشن، بس الفاميلي هيستوري ده حصل فيه سيبروفاسكولار ستروك، في فاميلي ثانيه حصل فيه رينال امبيرمنت، هل دي برضو ليها دخل ان انا بعد كده ممكن ادخلها في الاسسمنت عشان تبقى في الديسيجن بتاع التريتمنت والبلان بتاع التريتمنت؟
هو يعني بدون تعقيد الامور وبدون ما ندخل في equations، وببساطه جدا الريسك فاكتورز واضحه. في ريسك فاكتورز مهمه وخطيره زي الدايابيتس وزي الكرونيك كيدني ديزيز، دي ريسك فاكتورز مهمه، ودي اللي تخليني to start treatment early and to be aggressive with treatment and to reach lower levels of blood pressure، بدل ما بقول في كل الغرض بتاعي ابقى اقل من 140 على 90 في الناس دول الديابيتك واللي عنده كرونيك كيدني ديزيز يبقى اقل من 130 السيستوليك بلاد بريشر. فهنا باختصار شديد ان اللي يهمني ان انا اشوف الريسك فاكتورز المهمين، واحنا ما عندناش يعني الريسك ايكويشنز والبريدكشنز دول معمولين على بوبوليشنز مختلفه، فما نقدرش نطبقهم عندنا مباشره. انما مش عاوزين نعقد الامور، باين واضح الريسك فاكتورز. الفاميلي هيستوري اللي حضرتك اشرت اليها، فاميلي هيستوري ان الفيرست ديجري ريلاتيفز جالهم ستروك او جالهم هارت فيلير او جالهم كورونري ايفنتس ات يونج ايج، فده بقى بوزيتيف فاميلي هيستوري، وده يؤخذ في الحسبان لان ده بيخلي الشخص مور فالنربل مور لايبل ان هو يبقى عرضه ان يجيله كارديوفاسكولار ايفنت ات يونج ايج.
دكتور محسن، انا عندي سؤال بعد اذنك. دلوقتي there is a growing interest nowadays in the literature about including the estimation of coronary computed tomography and geography in the assessment of cardiovascular risk. Also, the calcium score as a part of the assessment of the cardiovascular risk. Would you advise these procedures?
ده الكلام ده بتاع البلاد الغنية، the rich countries that they can do computerized coronary angio and looking for calcium score. الكالسيوم سكور ليه scoring له يعني indications محددة إنما it is not part of the routine evaluation of hypertensive patients.
هو الكونسبت اللي حضرتك بتقول عليه ده اللي هو التولز النيو تولز دي او الاميرجنج تولز this is under the title of cardiovascular risk enhancers ودي احنا بنستخدمها في العيانين اللي هم at moderate risk to define who will get the benefit for treatment and who will not get the benefit. فهم risk enhancers actually is not a typical risk factor used في العيانين اللي عندهم at moderate cardiovascular risk to define which will get benefit from the treatment and who will not. I think you have a question.
The idea of having a cardiovascular risk estimation might be more worthy to be implemented on those who are having medium to lower risk to really better assess their risk to develop coronary or cardiovascular diseases. However, there are gray areas in between that may we add the enhancers or the coronary scores or even the others issues like the social and so on. But however, the idea we needed to be implemented rather than to discuss in many details whether it is there or not, or to put it or not. We need first to put the idea in the ground because the studies are telling us that physicians are not calculating or even not consider the other cardiovascular risk factors while they are taking decisions about high blood pressure. And that's why we do see patients in the CCUs who are not labeled as hypertensive, but they are pre-hypertensive, not labeled as diabetic, but they are having impaired fasting blood sugar. They are smoker maybe, they are obese, and this is metabolic syndrome. And once we calculate for these patients their cardiovascular risk, more likely they will be either moderate to high or high. And that's what, and these patients will have more chance if we detect them early to start them either with a statin or easy to have antihypertensive management, I guess. Wallahu a'lam.
Okay. For the sake of time, we will close this session and then we'll call on the chairpersons of the next session, Professor Ahmed Al-Ghalid, Professor Wafa Abu Al-Ainin, Professor Hussam Andil, Professor Yasser Sharaf, and Professor Muhammad Ramli.